السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الثالثة نكمل محاضراتنا في approach to patient with symptom or approaching to patient symptom. So we start today with approach to patient with ascites. What is ascites? Ascites is accumulation of a fluid within the peritoneal cavity. Normally, as anatomically saying, normally in the peritoneal cavity there is two thin layers of serosal membrane, namely visceral and parietal layer, which are lining the abdominal cavity, creating in between them a potential space. This space called the peritoneal cavity. Normally the peritoneal cavity contains small amount of viscous fluid, about 50 ml. The function of this fluid is to facilitate the movement of parietal over visceral layer without much friction. So ascites define excess accumulation of fluid within this cavity. This is the peritoneal cavity, and we see when there is huge amount or there is fluid accumulation, the resulting is ascites, and this patient has ascites resulting in abdominal distension. What are the causes of ascites? Ascites is a symptom per se, or a sign on examination we can find, but it is not a disease. So when we find ascites, we should look for the underlying etiology or underlying disease, which could be most commonly worldwide. Most common cause of ascites is liver cirrhosis, which accounts for 84%. Another cause is cardiac causes, which could be heart failure, restrictive cardiac disease, or constrictive malignancies, infection like tuberculosis, chlamydia infection, pancreatitis, excessive protein loss within the urine, nephrotic syndrome or in rare causes, hypothyroidism or a syndrome called familial Mediterranean fever. What about the pathogenesis of ascites? We will divide the pathogenesis into two types. We will discuss in detail the pathogenesis of ascites in patients with liver cirrhosis. Ascites in patients with liver cirrhosis results from either one of two causes, either portal hypertension or due to excessive water and salt retention. So, first, portal hypertension. You should know the blood supply to the liver comes from two main sources: hepatic artery and portal vein. Portal vein responsible for 70% of blood incoming to the liver, while hepatic artery responsible for other 30%. Hepatic artery responsible for O2 supply to the liver, while portal vein responsible for nutrition and solutes that are presented to the liver. So, portal hypertension defines increasing resistance to the blood flow in the portal vein, which could be anyway along the pathway of portal vein, but we discuss it if the increased resistance occurs within the liver. So there are three mechanisms for portal hypertension in patients with liver cirrhosis. Liver cirrhosis means there is fibrosis within the liver. So hepatic fibrosis, which define cirrhosis, will disrupt the normal architecture of hepatic sinusoid and impede the normal blood flow through the liver, which causes increasing resistance to the flow. When there is increased resistance, there will be increasing in portal hypertension, and then there will be back pressure throughout the course of portal vein till the capillaries. When there is increasing pressure within the capillary, there will be distension and leakage of fluid from the capillary into peritoneal cavity, resulting in ascites. This is the first cause. Second cause is by activation of hepatic stellate cell, which usually lead to small muscle contraction within the small vessel of the liver and further increase in portal pressure. Finally, cirrhosis is associated with decrease in endothelial nitric oxide synthetase production. This enzyme responsible for the induction of the production of nitric oxide. As we know, nitric oxide is a molecule that is naturally produced by the body and act as vasodilator. So when there is decreased production of nitric oxide, there will be vasoconstriction and increasing blood pressure, increasing pressure within the portal vein, and we return to the same point, portal hypertension. Next, compensatory sodium and water retention. In contrast to intrahepatic decreased production of nitric oxide, all other parts of the body in patients with cirrhosis characterized by increased production of nitric oxide. So, nitric oxide in patients with liver cirrhosis run in two pathways. Within the parenchyma of the liver, there is decreased nitric oxide production, while all other parts of the body, there will be increasing in the production of nitric oxide. And as we said previously, nitric oxide is a vasodilator, which means all vessels within the body, mainly subclinic vessel, will have vasodilatation. Vasodilatation of subclinic circulation resulting in pooling of blood and decreased effective circulatory volume, which means there will be decrease in the blood supply to the kidney because all the blood will pool within the subclinic vessel. So the kidney will perceive this as hypovolemia and hypotension and will act to activate renin-angiotensin-aldosterone system. With overproduction of aldosterone, this aldosterone will act on the kidney, causing sodium and water retention and worsening of fluid accumulation within the body. While pathogenesis of other causes of ascites could be malignancy, when the tumor lining the peritoneal or produce proteinous-rich fluid contribute to the development of ascites by increasing oncotic pressure within the peritoneal cavity, so act as a magnet for fluid. Same apply for TB, but in patients with pancreatic ascites result from leakage of pancreatic enzymes into the peritoneal cavity. We said the second most common cause of ascites is cardiac cause, which cause ascites by a mechanism similar to that of portal hypertension by increasing the resistance to the blood flow through inferior vena cava by increasing pressure within the failed right side heart. How we diagnose or how we approach patients with ascites? Number one, by history taking. We should specifically ask about the onset and duration of the ascites to see whether it is acute or chronic process. Is it progressive? Is it localized to the abdomen or involve other parts of the body, like bilateral leg swelling, testicular swelling, scrotal edema, or maybe facial puffiness and facial swelling? And we should ask specifically about associated symptom. If there is any pain or fever, which may signify underlying infection or peritonitis. Nausea, vomiting, meaning bowel congestion. If there is any jaundice or melena, which may signify chronic liver disease. If there is any change in bowel habit or weight loss, which may signify underlying malignancy. We should specifically ask about shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, which could signify underlying cardiac failure, or cardiac disease. Next, we should ask about risk factor for chronic liver disease. As we say, liver disease is the main cause of ascites, so we should specifically ask about risk factor for liver disease, like alcohol intake, drugs that cause liver injury, if the patient has any history of needle injection or blood transfusion, if he have history of sexual relationship, history of travel is important. Now we reach for next step in the approach, which is diagnosis. In the diagnosis of patient with ascites, the most important part is by aspiration of fluid and analyze that fluid. The process of aspiration of fluid is called paracentesis. So paracentesis is a simple bedside procedure in which a needle or small cut passes transcutaneously to extract acidic fluid from the peritoneum. The lower quadrants of the abdomen are the most frequent sites for paracentesis, and most specifically, the left lower quadrant is preferred over the right because of a greater depth of the ascites, thinner abdominal wall, and there is no cecum in the left side. You should know paracentesis is a safe procedure even in patients with coagulopathy and relatively has small number of complications, could lead to minor abdominal wall hematoma or injection site infection, etc. Now we aspirate fluid. When we aspirate fluid, first we need to look the general appearance of the fluid. Look, this is a clear acidic fluid, while this is turbid color fluid, which signify infection. This acidic fluid is white, milky fluid, what we call it chylomperitoneum, which characterized by high amount of triglyceride. Acidic fluid could be red or bloody in color, which occur in patients with underlying malignancy or traumatic abdominal injury. Could be, in rare cases, a black in color, which occur in patients with pancreatic necrosis due to acute pancreatitis or metastatic melanoma. After gross appearance, we need to do some lab investigation for analysis of which type of fluid we're dealing with. All this to reach underlying diagnosis. The most important part is protein assessment of the acidic fluid. So we will send the patient for acidic fluid albumin and acidic fluid total protein in addition to serum albumin. We will need to do this to calculate serum acidic albumin gradient, or SAG. SAG is useful to distinguish ascites from portal hypertension from non-portal hypertension. So if SAG is more than 1.1, it indicates portal hypertension, which could be many causes. So SAG meaning serum acidic albumin gradient, which will result from subtracting acidic albumin from serum albumin. If SAG ratio or result less than 1.1, it could be tuberculosis, malignancy, pancreatitis, nephrotic syndrome. While if SAG is more than 1.1, then total acidic protein level need to be calculated, which we sent previously. If acidic protein level more than 2.5 gram, indicate that hepatic sinusoids are normal and are allowing the passage of a protein into the ascites, as occur in cardiac ascites or obstruction to the inferior vena cava. While if acidic protein level less than 2.5 gram, it indicates that hepatic sinusoids are damaged and scarred and no longer allow the passage of protein, as occur in patients with cirrhosis, massive liver metastasis, or late in patients with Budd-Chiari syndrome. Other tests need to be addressed, including acidic fluid for white BC differential, gram stain and culture sensitivity, looking for infection, acid fast bacilli and deaminase level, looking for if we have suspicion of peritoneal tuberculosis, serum amylase to exclude the possibility of pancreatitis, and finally cytology, looking for malignancies. Treatment. So, as we see, treatment depends on underlying etiology. What is the cause of this ascites? This needs to be addressed. In this lecture, because the most common cause, we said 84% of cases of ascites is liver cirrhosis, so we'll discuss a few points about the management of ascites in patients with liver cirrhosis. The main step in the management is to restrict sodium intake to less than 2 grams per day. If patient has hyponatremia, which is common in patients with liver cirrhosis, we advise the patient to decrease fluid intake. And third, most importantly, to start pharmacotherapy with oral diuretic. So, previously mentioned that one of the main mechanisms of ascites is by excessive secretion of aldosterone and increasing sodium and water retention. So in order to treat patients with cirrhotic ascites, we need to address this. So spironolactone is the main line of pharmacotherapy to treat ascites, and usually used in a combination with furosemide, a loop diuretic, in a dose that can be progressively increasing to see the response. If the dose of spironolactone reach maximum of 400 and furosemide maximum of 160, and ascites is still huge, not responding to diuretic therapy, this signifies refractory cirrhotic ascites. So, refractory ascites defined as persistence of ascites despite sodium restriction and maximum dose of diuretic. At this point, we can add another pharmacotherapy, which is midodrine, alpha-1 adrenergic agonist. If no response, then we go more aggressive therapy by repeated paracentesis. We ask the patient for frequent visits, and we aspirate therapeutic amounts of acidic fluid, but with replacement of plasma albumin with each aspiration. If the patient does not or refuse frequent visit to the hospital, next, transjugular intrahepatic shunt. This is the liver, this is the portal vein, and from the liver, this is the hepatic vein. This is input, this is output. Transjugular intrahepatic shunts or tips perform by putting a stent connecting the portal vein to the hepatic vein, so the blood will flow directly from the portal vein to the hepatic vein, bypassing the cirrhotic liver. So bypass all resistance that produces from the fibrosis within the liver. Ascites could result in a number of complications, mainly and most commonly infection, like spontaneous bacterial peritonitis. Acidic fluid could migrate to the chest and result in hydrothorax through anatomical fenestrate presented in the diaphragm. weight loss and protein malnutrition, which may signify the underlying chronic disease, and finally, hepatorenal syndrome or renal failure. Thank you very much.